Good afternoon, everyone. Thank you for joining us this afternoon. My name is Jennifer Herr, and I am the Chief Officer in the Ministry of Health and Culture. I'm joined this afternoon by the Honourable Premier and Minister for Health and Culture, the Honourable Alden McLaughlin. I'm also joined by the Acting Chief Medical Officer, Dr. Elizabeth McLaughlin, the Acting Medical Officer of Health, Dr. Samuel Williams, and the Director of the Mosquito Research and Control Unit, Dr. Bill Petrie. We're here this afternoon to provide an update on our preparations for the Zika virus. I'm going to ask each of the panel members to speak, and there will be an opportunity for some Q&A at the end. So I'll just ask you to hold your questions until everyone has had an opportunity to provide their update. So with that, I'm now going to turn it over to the Honourable Premier to offer some remarks. Premier?
Thank you, Jennifer. Welcome, everyone. In light of the confirmations of the Zika virus in the United States and Jamaica, and the declaration by the World Health Organization yesterday that Zika is now a global emergency, government wants to assure the public that we have been taking appropriate actions to respond to the possible introduction of the Zika virus to the Cayman Islands. Just a couple of months ago in December, the Pan American Health Organization expressed confidence in the level of preparedness of local public health officials, including the Mosquito Research and Control Unit, to detect, respond, and control the spread of the Zika virus if there is a case here. As you all know, Cayman is no stranger to mosquito-borne diseases. We were well prepared in combating dengue and chikungunya, and we are now confident that we will have control of Zika if it reaches our shores. I want to emphasize that the Zika virus is not yet in Cayman, but given our proximity to Jamaica and Central America, in all likelihood, the virus will find its way here in the coming months. As I'm sure you know, the reason we are so concerned about the Zika virus is the potential link between Zika in pregnant women and microcephaly in their babies. There are other health risks that are potentially linked to Zika. Until we know more, as we said in our press release in December, residents, but particularly women who are pregnant or planning to become pregnant, should take extra care to protect themselves from mosquito bites, especially when traveling to areas where the virus has been confirmed. Those who contract the Zika virus will have symptoms similar to those of dengue and chikungunya, with fever, muscle and joint pain, conjunctivitis, headache, nausea, and rash. And while there is no treatment for the virus, complications are rare. The Mosquito Research Control Unit is recognized as being one of the best and most experienced mosquito eradication entities in the region, and because of that, Cayman has been very successful in controlling the numbers of Aedes aegypti. This is an urban mosquito that lives around homes and yards and does not live in swampy areas, as is the case with the majority of our mosquito populations, making the Aedes aegypti harder to eradicate. That means a more targeted approach is necessary. Dr. Bill Petrie will discuss in more detail the various methods that MRCU uses to control mosquitoes generally, but the Aedes aegypti specifically. It is because of the work of the MRCU that we know where the greatest numbers of the Aedes aegypti mosquitoes are on Grand Cayman, so we are able to concentrate mosquito elimination measures in those areas. Fortunately, the Aedes aegypti has not established itself on the sister islands. While the constant combat against mosquitoes is always of uppermost importance to government and the relevant stakeholders, it is also incumbent on each of us to ensure that we do everything we can to reduce mosquito breeding. On government's part, we will be redoubling our efforts in controlling Aedes aegypti, including finding any additional resources needed to address this concern. I am joined today by the men and women whose job it is to keep our people, residents, and visitors healthy and safe, and they will go into more detail about the mosquitoes, eradication efforts, and what is being done about the possibility of the Zika virus in the Cayman Islands. After they have spoken, we will entertain any questions you may have.
Thank you very much, Premier. I want to acknowledge the Councillor for Health and Culture, Councillor Roy McTaggart. Thank you for joining us this afternoon, sir. I'm now going to ask Dr. Williams, who is the Acting Medical Officer of Health, to provide us with an update on some of the preparations from his office's perspective.
Thank you, Ms. Jennifer. Thank you and welcome, everyone. I first would like to start by assuring everyone that even though we are yet faced with another imminent threat, the Zika virus, I'm convinced, and my office are convinced that we will get through this one. We are prepared to affront this threat, and preparedness has come from before when we faced dengue and chikungunya. And we have been, like the Honorable Premier has mentioned, we have been praised by the Pan American Health Organization for our level of organization and our surveillance system. I want to give a little bit of background about the disease. The Zika virus was first isolated in 1947 in Uganda, in Africa. From that time to up to 2007, had not been any major outbreak of the disease. However, in 2007 was an outbreak of the disease outside of Africa and Asia. And more recently, in 2013 and 14, it was a big outbreak of the disease in the Polynesia island and the Pacific region. From that outbreak, it was actually over 8,000 suspected cases and 383 confirmed cases of Zika virus. There were at that time was some association between this outbreak and some neurological disorder that we will mention later on. In April 2015, an outbreak was identified in Brazil, and from Brazil has spread to all the Americas, to all 4 regions of the Americas, and currently 27 countries in the region of the Americas have reported cases of Zika virus. More concerning, actually, because cases have been reported in Jamaica, in the USA, in Florida, in Honduras and Dominican Republic, and the proximity and also the constant traveling between those places and the Cayman Island. I want to mention that, and the Premier already mentioned some of the symptoms of the disease. Only 20% of patients actually develop symptoms. So we have 80% of people who could be infected and they have no symptoms at all. And even though the patients who have symptoms, the symptoms are usually mild. So these complications that we will mention and we'll discuss today associated or that may be associated with the disease are rare and they're not frequent at all. But they're serious, they could be serious, and that's why we're taking this very serious approach to the condition. From the time that the person gets bitten by a mosquito to the time that they develop symptoms, what we call incubation time, it's normally around 4 days, but it could be anytime between 3 to 12 days. The symptoms, like I said, are usually mild. They're self-limited. They don't last more than 5 to 7 days. Treatment is supportive, and basically with medication for pain and fever, and avoiding medication that contain aspirin because of the risk of developing hemorrhage, because of the symptoms are similar to dengue as well. Because of this, we have collected some data on our baseline number for the 2 main conditions that have been under investigation because of the possible association with the Zika outbreak, and that is for microcephaly and Guillain-Barré syndrome. Microcephaly is a condition where the baby is born with the head is smaller due to a lack of development on the brain. And there are many causes of microcephaly, genetic like Down syndrome, other infection like rubella, and also toxic. Alcohol can cause microcephaly. But the association has been, because in Brazil, in the area of Brazil where this outbreak has been happening, there also been seen an increase of the number of microcephalus. So it's actually an epidemiological association, but the direct link had not been established as yet, and there's a lot of investigation going on this. For the Cayman Island, these conditions are not, like I said, they're not common. We did have, we have 2 cases of Guillain-Barré syndrome which is a neurological disorder that starts with paralysis of the muscle, usually called ascending paralysis because it could turn in the muscle in the lower limbs, and it could ascend up to the respiratory muscle and cause some serious respiratory problems. The patient will need ventilation. Recuperation is usually slow, take weeks to months to recover from Guillain-Barré syndrome. We have one case of Guillain-Barré syndrome reported in 2009, and we have another case in 2015. For microcephaly, we have one case in 2011. We have 3 cases in 2012. The good thing about having this baseline that now we have a number that we can compare in case that we have to experience an outbreak of Zika virus on the island, that we can compare if we get more cases with our baseline. On last Friday, we have a multi-sectorial meeting with different departments, a government department from the Cayman Island. It was over 40 stakeholders on that meeting, including senior officials from the Ministry of Health, including the consul and the chief officer and the deputy chief officer. The chief medical officer was present, the medical director from the HSA, also all the head of department from the HSA, especially for pediatric, obstetric, emergency, and general practice. The director of the lab, the director of the MRCU was also present at the meeting, and other main stakeholders from the environmental health, tourism, and custom, and other agencies. During that meeting, we actually assessed our level of readiness to offer this. And so after the meeting, before, but even after the meeting, I was even more confident that we are actually in a good position to affront the imminent threat of the Zika virus to the Cayman Island. During the meeting, it was also recommended that we maintain and enhance our surveillance system. We will continue to survey not only for communicable disease undifferentiated fever, but we also have started surveillance for Guillain-Barré and microcephaly, and it's part of our weekly surveillance as well for those conditions. We discussed, Dr. Peter discussed during the meeting some of his plans, or the plan of the MRCU to affront that, and he will talk more about that in a few minutes. We were reaffirmed by the medical director of the hospital that we have all the adequate supplies and the facilities to treat these conditions if we have any of these complications also. And basically, it was stressed the important and the main message is to control, vector control, the control of the mosquito, and not only by MRCU, but also by the public, which plays a big part on the controlling of the mosquito virus. Thank you.
Thanks very much, Dr. Williams. Dr. McLaughlin?
Good afternoon, everyone. I'll speak largely to the clinical preparation that is available. Guidelines for the management and the assessment for Zika have been supplied to all physicians, both public and private. And that's because our patients go anywhere in terms of accessing care. It is clear from some of the responses we have had that the clinicians out there are considering Zika. We have the current guidelines, and all guidelines are interim at the moment because this is an evolving disease process. Also supported by CARFA on which particular samples they will test for Zika. At the moment, because we have no confirmed cases in Cayman, these will be cases that have a travel history from an affected area at the present moment. Obviously, should the virus become established here or we start having what we call local transmission, then the process will change differently. The usual point of blood collecting and sampling will be done at HSA, either the emergency room and sometimes the general practice. All of the clinicians there are aware. They're also aware of potential complications in terms of pregnancy and the Guillain-Barré syndrome. We would also like to stress that these conditions, the microcephaly as well as the Guillain-Barré, are things that occur otherwise in medicine. So it is not, while Zika may be new to this region, it is not, the management of the complications of it are not necessarily new to the clinicians. Additional point is that we do want to encourage people to be proactive. Do not be afraid to call or to come to access care at this moment, but also listen to what is being told, because the way it will be done will change with time. It doesn't mean that everyone needs to come to the emergency room all at once. It means that you can talk to your regular doctor, and that's what we would encourage. Communicate with your physician first, and then we move forward at that point. Obviously, we still continue to advise females who are pregnant or planning to become pregnant to avoid travel to protect infected areas, and also to try to prevent being bitten by mosquitoes, either here or there, as much as possible. Yeah. Thank you.
Thanks very much, Dr. McLaughlin. I'll now ask Dr. Petrie to outline the Mosquito Research and Control Unit's efforts against the Aedes aegypti.
Good afternoon, everyone. What I want to focus on is what we are going to do at MRCU, and also what the general public can do in this context. Because this is a different mosquito than dealing with swamp mosquito, bush mosquitoes as we call them. Okay, so starting off, the good news is that we have experience in dealing with this type of thing from dengue and chikungunya, especially the chikungunya campaign. We learned a lot too. This is a potentially much more serious public health threat than previously, but we do have the expertise. We have the necessary equipment and trained staff. That's a very key point. We also have a commitment from government, from the Premier, that we will be provided with the resources that we need, that we've requested. That is good news. Also, what I want to say is we have a contingency plan. And that plan consists of an action plan in 2 phases. What I'd like to do is just outline this plan. I do have some information I'd like to mention on the mosquito itself, because I think that's also important. Some of it, I guess, can wait until question and answer section. But the key point here is the action plan. And we have 2 phases to this plan. One is the preemptive phase, before we get the virus. The second phase of this action plan is after we get the virus. What do we do then? So the first phase, this preemptive phase, the key to this, to any disease, emerging disease situation, vector-borne with this mosquito, is intervention at the adult stage of the mosquito. It's more important than larviciding, than treating the larvae, the immature stages. It's the adult mosquito that transmits the virus, so it's intervention of at the adult stage. So this will involve, targeting the adults will involve the use of 2 insecticides, 2 different products belonging to 2 different classes of insecticide. The key there is that we shall rotate them in order to reduce the risk of getting resistance to either one of these products, which is an important factor in dealing with Aedes aegypti. So phase 1 of this plan, the first thing will be twice weekly aerial applications, mainly West Bay and Georgetown, targeting South Sound and out to Red Bay, because these are areas that we know where the highest concentrations of Aedes aegypti exist. We will treat the eastern districts, but with less frequency. I say twice weekly treatments because Aedes aegypti is a very fast developing mosquito. It can develop within 5 days if it's warm temperatures. So once weekly is not enough, as it would be with other mosquito species. So you want to cut that development cycle of the mosquitoes. So we plan twice weekly sprays, 3 main areas we will be concentrating on, and we'll be rotating the 2 different products, insecticide products that I mentioned. The second thing is we have a number of fogging trucks, vehicle-mounted fogging machines, which I'm sure you're aware of. You've seen them. We will be utilizing those in more concentrated areas. So, for example, during the chikungunya campaign, one thing that worked well was Georgetown was divided into 8 sections, and one truck could deal with 1 section at a time. For the fogging machines, we will not rotate the 2 chemicals. We will only use 1 of those products. We don't need to rotate with those quite so much. The next thing we will be doing is coming down in scale here from the aircraft to the vehicles to what's called thermal fogging, whereby the operators, the disease prevention officers, will utilize, it's a handheld machine, and it gives out a large plume of insecticide fogging. It looks like smoke. It's actually a heated spray. This is for a much more concentrated area, so just a few houses perhaps in a block. Again, you're treating from large to small areas. We will continue in this phase of the plan. We will continue our traditional methods, which are still ongoing, which really is a case of boots on the ground, our disease prevention officers, house-to-house inspections around yards. They inspect and they treat at the same time and also give information to the residents. We'll continue to do that, and we also intend to use an experimental device that we're having some success with. It's called a lethal ovipot, just a fancy term for an egg pot, and mosquitoes like to come to this device to lay their eggs. And this device, while the mosquito comes to lay her eggs, the mosquito picks up a minute quantity of an insect growth regulator. The mosquito then carries this insect growth regulator to the next egg-laying site. Unlike other mosquitoes, Aedes aegypti lays its eggs in different sites all over the place, and it's a container breeder, so pots and buckets and so on. We'll continue that part of the program in phase 1. Phase 2, once we have evidence that we have the Zika virus here, which we believe will happen rather than if, we'll move into phase 2 of this action plan. Essentially, it's an intensified version of what I've outlined with some differences. It will be intensified spraying, aerial and vehicle mounted, focusing only on the adults. We'll probably at that stage not bother with focusing on the larvae. You want to get to the adults, kill the adult mosquitoes to stop transmission or possible transmission. We'll also redeploy other staff at that stage. Anyone who's working on anything else will be brought in, so everyone will be working on that alone. The vehicle mounted, the fogging trucks, probably do morning and evening. The aircraft will continue to treat. And we will then be able to, in this phase, concentrate the vehicles, and particularly the thermal fogging that I mentioned, into those locations where we know the virus is located. We get information from the Health Services Authority as to where any patients reside. We don't get confidential information, but we do get information as to where any patients reside and also where they work. So we can then focus on treating these particular areas. We will probably cease the use of the pots I mentioned because we're going to use the staff in a much more intensified way. One thing about the phase 2 of this action plan is that we recognize that we need to be flexible. We need to, unlike just a program which will exist in phase 1, in phase 2 we need to be flexible to be able to respond to the circumstances, how this virus unfolds. It seems to be somewhat different from dengue and chikungunya. It seems to be breaking all the rules as far as things go. So we need to be able to be flexible in our response. Also, I should add that the lab work, our MRCU lab, in backroom scenes here, we are currently acquiring some laboratory equipment whereby we will be able to test for the presence of the virus using what's called PCR, real-time PCR. Basically, you're looking for the genetic material of the virus. The point of this is that we can, or we will be able to detect presence of the virus. We can get a result in less than an hour. We can get a result in 40 minutes. So we don't need to wait for test results coming back from overseas. We are not a human diagnostics lab. We will not be using that to inform patients. Rather, for us, it's key to getting to those areas. We get information from where the parent is. The HSA supplies us with a sample, usually a blood sample or a serum sample from the patient. We get a portion of that blood sample. The rest is sent overseas for testing, the official testing. We have very good links with the HSA, and we are given that sample in a very timely manner. We can check immediately. We will know that day, the following day, where we need to get to, because we can't wait 2 weeks, 3 weeks. By that time, it's too late for us to intervene. So that's going to be an important part of the program, which will not be visible, but will be critical nonetheless. And also, something that's new is that this new piece of equipment, we will be able to test for dengue, chikungunya, as well as Zika, in the event that scenario should unfold. We can also use the equipment to test for the virus in mosquitoes. And we'll do so from the outset. We will get a whole series of 0 results, but it will give us the opportunity to use the equipment and to train staff into how to use it, how the protocols work, and so on. So that will be quite useful. Also, once we move into phase 2, if we are able to test for the virus in mosquitoes, that will be very useful also to pin down where concentrations of the virus may be, in addition to concentrations of the mosquito. I want to mention the 2 products, the 2 insecticides that I mentioned earlier on. One of them belongs to a class of insecticides called pyrethroids, which is the safest class of insecticides we can use. One of them belongs to a class called organophosphates, not the preferred class of insecticides to use, but, and this is an important point, we discovered through research work that was conducted at MRCU, actually a PhD that was done here in collaboration with the University of Liverpool School of Hygiene Tropical Medicine, that our Aedes aegypti here are resistant to almost all the insecticides that are available for use. And until very recently, we only had the use of the organophosphate. The active ingredient is chlorpyrifos. The trade name is mosquito mist, in this case mosquito mist 2. Recently, we heard about a new product. The brand name is DeltaGuard. It's not a new active ingredient. The active ingredient is called deltamethrin, but it's a new formulation. And we tested it out here and discovered that it does kill the Aedes aegypti here, which is very good news. Also, this new product has been designated by the EPA in the United States as a reduced risk pesticide, which is good news for us. Both of these products are approved by the US EPA for use in public health scenario. So that we will be able to rotate these two chemicals. We will focus mainly on this new one, the reduced risk pesticide. It's very effective against the Gypday, but we will rotate because we don't want to lose the use of it. And I think that outlines the plan that we have, the plan of attack that we have in mind. I was thinking on a way to work, when are we going to be able to implement this plan? And actually, we started last night, which was good news to hear. The staff at MRCU are busy right now preparing the vehicles, the fogging machines. We're mounting 2 extra ones. I passed on the good news from the Premier that we are to be given extra resources. Guys are working on the aircraft. We've already received some of the insecticide that we need. We've got some more on order. So we are actually underway. It will be stepped up in the coming weeks. Okay. Thank you.
Thank you very much, Dr. Petrie. Honorable Premier, did you have any final remarks that you wanted to offer before we open up the floor for questions?
I just wanted to thank the entire team that are here for all the work that they have done over the course of many, many weeks, now months, actually. Lots of people seem to believe that we just sit around and wait until something happens and then respond. Tremendous amount of work goes into planning these programs in the eventuality that we face a situation like this. And I think the explanations by both, the medical doctors and Dr. Petrie as well has given a clear indication of the tremendous effort that has gone into getting us to this state of readiness. As far as the government is concerned, obviously there was mention of the meeting, the important meeting of stakeholders last week. Caucus received a full presentation yesterday as well from the team, and they've indicated to us what they need in terms of resources, additional resources, to make sure that these programs work, and we've made that commitment. Again, I just want to thank everyone for all the work that's been done to get us to this point, and to say at this stage we're happy to take whatever questions the media may have.
Thank you. We are recording today, so if I can ask you to use the microphone, introduce yourself, and ask your question.
Hi, I'm Joe Avery with Cayman 27. I just had a question more on the medical end of things. I have a friend who's treated microcephalic babies and says the mortality rate is not good. What if somebody were to have microcephaly, what kind of life expectancy do they have? Because this person says everyone that she's treated with it has perished.
Yeah, microcephaly, like I mentioned, is multifactorial. So it's different causes of microcephaly, different grades of microcephaly. So it depends on the case. The mortality is high for microcephaly, but some patients do survive with microcephalus, and they will experience some type of mental problems, but the mortality rate is high, as you have mentioned. It's true. And
what would be the, I guess, infection rate of this? Is this something that spreads more or comparable to or less than dengue or chikungunya, the two that we have been used to in recent years? I don't know who that's for, but.
Remember, it's a similar disease to, it's a viral illness similar to dengue and transmitted from the same mosquito that transmit dengue and chikungunya. It has been spreading quite rapidly in the region of the Americas, but the infectivity is not different from dengue or chikungunya at this point.
Will there be more resources committed to providing free birth control, perhaps to women who definitely do not want to get pregnant during this time where the Zika could be a potential threat?
Well, there's no recommendation yet from the WHO or PAHO for a female not to get pregnant. The recommendations actually are for females that are pregnant or planning to get pregnant or that could get pregnant to take all the necessary measures not to be bitten by the mosquitoes and not to travel to the area where local transmission has been established.
And I have one more for Dr. Petrie. How were our genetic modification or our GMO mosquito efforts, are these helping us control Aedes aegypti, or as some fear in more of the social media segment of our population that, you know, we're creating a monster by messing with nature, like a monster mosquito?
We're not currently using genetically modified mosquitoes. We are in discussions and negotiation with the company. It's a UK company called Oxitec, who are working very hard in Brazil at the moment. We carried out 2 very small pilot studies, really. They were field studies several years ago, which proved very successful, although it was an idealized situation. It really going from the lab to the field. It was not operational. It was to see if in principle, if the technique could work, and very promising results. But we, as I said at the outset, we have a number of control methods that we can use. The use of genetically modified mosquitoes would certainly be one of those to be considered. There are a couple of others, but in this particular case, what we need to do is to attack the adult mosquitoes and do it quickly. The use of genetically modified mosquitoes would be a long-term program, should that go ahead. Also, you'd run into issues, not insurmountable issues, but you'd run into operational issues whereby if you're involved in a very intensive aerial spraying and ground spraying program and releasing lots of sterile male mosquitoes at the same time, you're going to kill the very mosquitoes that you're releasing. So you'd have to balance that, should you be doing so. We're not doing so at the moment, and that's not part of the initial scheme, certainly not at the moment.
Just, can you clarify, Dr. Petrie, the mosquitoes that were released as part of those trials?
Yes.
There wouldn't be any left.
I've had a question about how many of those mosquitoes were still here, and the first trial was 2010, and I think the next one was 2011 or 12. The mosquitoes live about 3 weeks if you're lucky, so there's certainly none of those mosquitoes here in Cayman. And I need to stress that it's only male mosquitoes that are released, and male mosquitoes don't bite.
Okay, thank you.
Charles Duncan with the Compass. Dr. Williams or Dr. McLaughlin. So we've heard some warnings in South and Central America about public health officials saying don't get pregnant for 2 years. Is that something that you think is a reasonable practice for them, and is that something we'd have here if it became transmitted locally?
At the moment, the evidence out there is pretty soft either way. Infection with it usually clears within 3 to 4 weeks. The answer truly in the length of time would lie on whether we can actually prove that Zika virus is actually responsible for the microcephaly, and actually how does it do that? Is it the developing fetus, which is what is suspected more than likely, or has it damaged something within the female's reproductive system? If the damage is done to the eggs of the reproductive system, then that would be a different issue. If it is within the developing of the fetus, then your delay in pregnancy would actually be just during the outbreak and maybe a month or so afterwards to prevent somebody who has an infection that's not yet blind. So some places have said more reasonably 6 months to 6 to 12 months avoidance, because there's quite a bit of unknown. But there's no one that's absolutely said to anyone. Obviously, in Brazil, they're dealing with a crisis, so your response will be a little different depending, and they clearly have over 4,000 microcephaly. So something has triggered this event, whether it's Zika or some other confounding issue. That is where the research needs to tell us, the science needs to go.
Okay. Are there any other questions for the panel? No? Okay. Premier, did you have any final remarks to offer?
No, just to thank the media for coming on such short notice.
Sorry, I've just been reminded by Dr. Petrie that one thing we do want to highlight is the role that individuals and the general public plays in helping MRCU with the work that they're doing. So if you just give Dr. Petrie a few more minutes of your attention, he's going to address that for us.
I did say that two parts to this. One thing, what MRCU is going to do, what we've already started, the two-phase action plan. However, with Aedes aegypti, and I do need to touch on a little bit of the behavior of the mosquito because it's relevant, but with Aedes aegypti, we need to ask the general public, advise the general public to help us and help themselves in combating this disease and this mosquito. Aedes aegypti only breeds around the home. It only breeds around houses and in yards, also inside houses, but here more we're focusing on in yards. It doesn't breed in mangrove swamps or bush or anywhere else. It also doesn't even breed in pools of standing water. It's a container breeder, what's referred to as a container breeder. So we're talking about buckets and drums, buckets and drums. I can say it again, buckets and drums. Our guys come in with a sheet, we had to define the larvae. It's buckets and drums. Containers like about this size are favored by Aedes aegypti. So what we would encourage residents to do, inspect your own yard, have a look around. The mosquito does not travel far. It stays within the confines of where it's hatched and where it flies. It only bites humans. Twice a week, just take 10 minutes to go around your yard and turn up buckets, cover drums, plant pots, the saucers underneath the plant pots. We find them there all the time, kiddies' toys, paint pots, you name it. Discarded tires, that's another one. That's a favored egg-laying site and development site for Aedes aegypti. So we want to encourage people to take a look around. I've taken a look around my yard. We've taken a look around our premises at MRCU and at the hangar. And this is something that's not too difficult to do. We will assist, of course, but it really does help individuals and residents and help us to reduce the breeding of this mosquito. Fix your screens, stop them coming in the house. Another thing I should mention, a bit more difficult, it tends to get missed out, is Aedes aegypti also breeds in roof guttering. More difficult to check, but we are going to intensify that part of the inspection program as we go. You've got to carry around a step ladder or a ladder or whatever. And if people want assistance with that, then that's what we are there to provide. A couple of points that I think need to be clarified or re-emphasized. Aedes aegypti, and it's probably the most difficult mosquito in the world to control, along with its sister mosquito, Aedes albopictus, the Asian tiger mosquito. But Aedes aegypti is a day biter, and this is something that we've tried to stress. It doesn't come out at sunset like most mosquitoes. It doesn't behave in any other way like most mosquitoes. So it's a day biter. We have found here through our research slightly different times from, say, Trinidad, where they've looked at it, and in Africa. We see it biting here up to 5 o'clock, even up to 6 o'clock, depending upon the time of sunset. But it doesn't come out at sunset. It's not active after dark. So if you're going to protect yourself and avoid being bitten, it's during the day that is the key. I do just want to also re-emphasize this point about, I want to commend the editorial in the Compass today Excellent information, in my opinion. There is one part that needs to be technically corrected, and that is Aedes aegypti does not breed in these pools of standing water that we see about the place. We treat those pools anyway, when we can, as and when we can. Sometimes the pools don't last long enough, so we won't bother treating them. It's not Aedes aegypti. Focus on your yard, buckets and drums, pots, and so on. And we would encourage the general public to do so, to help themselves and to help us reduce the population of Aedes aegypti.
Okay, thanks very much, Dr. Petrie. Joe, you had another question?
I thought of actually two other questions on the health side. First, I heard that it's like chickenpox. Once you get it, you're done. You can't get it again, Zika. And secondly, oh, sorry. Let me reboot those. I've heard that if you get Zika virus, you can only get it once, kind of like chickenpox, like you can't get reinfected. Also, in terms of microcephaly, when can people determine, in the pregnancy process, when a fetus is stricken with that? When is that able to be deduced?
The answer to your first question is yes. Once you get the Zika virus, you develop immunity against the disease. And microcephaly can be diagnosed during pregnancy with an ultrasound that will show the head circumference to be smaller, and also you can show some calcifications on the brain, which is a part of the microcephalus. Also, it can be done on patients who come to for a risk area, or female patients have been diagnosed with Zika virus. If they're pregnant, their obstetrician will decide if the patient needs to be tested for the testing, and then amniocentesis can be done, and it can be diagnosed that way as well.
Thanks very much. Okay, thank you all for coming this afternoon. Just to let you know, the ministry does plan to issue regular updates as the situation develops with the Zika virus. I want to encourage everyone, as Dr. Petrie outlined, to play your part, do your part, to help the MRCU reduce the population of the Aedes aegypti, which is the vector for Zika. You can monitor our ministry website for more information, which is www.ministryofhealth.gov.ky. You can also like our Facebook page to make sure that you get regular updates from us as well. Thank you all very much for coming this afternoon, and have a great evening.